Hi, everybody. Welcome. It is Ella and Emma.
Hi, good morning.
Hi, morning.
Chris, are you joining us? Oh, there he is.
Check if you can hear us in the chat.
There we go.
No, if you can't hear anything, obviously also let us know, but they won't be able to hear. But yeah. So over to you guys.
Thank you very much. Let me share my presentation if I can. Give me a second. Oh no. Give me a minute. Sorry. 2 screens. This is when I try and share my screen, and you're going to end up seeing my desktop full of lots of different things. This is not going well. Emma, you should have done this bit. Can you see a presentation? No. Can you see one now? Yes. Good. Right. I'm back in the game. Welcome to the Healthcare User Group. Thanks for coming along. Obviously, most of you might not be used to Remo, so it's a bit new to everybody. So just to kind of give you a bit of an idea of what happens is you will have noticed that you will have landed into a table. So it works like a conference. So there's lots of tables, and you can move tables and talk to different people. So if you want to move to a different table, because you can hover over and see who's on the different tables, you can double click on another table and you will jump across. If you you need to turn your mic and camera on so that other people on the table can talk to you, or you can use the chat facility if you want to remain anonymous. So there's no pressure to network if you don't feel comfortable, but there is the option. After we've done, we're going to do some introductions now, but after we've done all the main presentations, we're going to do some bit of networking. So from 11 o'clock, there'll be opportunities to network, and we've named some tables, lots of different things. So there's tables that hopefully might appeal to you. So we've got a table. So just underneath the table, there's a little name tag. So we've got a table for anyone who's interested in catching up with other people around acute services, one for community, one for mental health. We've got Lorna and Simon as Zen Masters, who you can go and talk to about some anything related to Tableau that you might have queries about, any help you want. They are your gurus that might be able to help. We've got a server table. We've got a data modeling table. We have got one for our central services, ALBs. So lots of stuff for lots of people. So if you want to join any of them tables, then you can do. So just to kick off, I don't know whether people have been to the normal healthcare user group that's normally run in London, but we've been running for about 3 years, and this is our virtual one, first virtual one, sorry. So bear with us if it doesn't quite go smoothly. As you can see, even I'm trying to work out how to share a screen. So yes, we have a hashtag. So if you want to start tweeting or putting stuff on LinkedIn, please do. That's our hashtag. Before we kick off, if I can make the slides work, I just wanted to say a massive big thank you to Simon Beaumont, my good friend, to say that he's been running the healthcare user group for the last 3 years, and he's passed the reins over now to a new crew who are going to take over as he's kind of stepped out of healthcare a little bit. So he's stepping back from running the group now. So, but I just want to say a big thank you, because he established the group, has grown it, and brought loads of people together over the years and done some fabulous presentations. So thank you, Simon. So now I'm just going to introduce the new crew. So this is us, and so you can see our faces rather than the pictures of us. So I'm Ella Worsdale. I'm the head of information at Pennine Care, which is a mental health and specialist trust in the east of Manchester. That's my Twitter handle. Feel free to follow me. I've been using Tableau for about 5 years and absolutely obsessed. I got made a Tableau user group ambassador last year, which I'm really proud of, and actually run 2 user groups, this one and the Northwest Tableau user group. So if you're Northern, please come along. Or in fact, anyone come along. But it is based in Manchester normally, but again, we're doing them virtually. So that's me. Chris, do you want to introduce yourself?
Hi, I'm Chris Dixon. I was one of the earliest NHS Tableau users back in 2010, and clearly I no longer work within the NHS. So unlike Emma and Ella, I don't have that first-hand frontline experience anymore, but I am supporting a lot of NHS trusts in using Tableau. Again, like Ella, there's my Twitter handle and my email. Please do feel free to contact me, reach out whenever you want. And I can absolutely tell you the Northwest tug is great. One thing I love about this COVID period is all the virtual tugs. I'm going to Birmingham. I'm going to Manchester. I've been to America for Tableau user groups that I would never have had the chance to go to before. So it's great. So welcome, everyone. And to me, bottom right, I've got Emma. So Emma is, I'll let you introduce yourself, Emma.
Hi, I'm Emma. I've been to a few Tableau user groups before, but this is my first one as a leader, so that's super exciting. I'm a 2018 analytics graduate, and as part of my first placement, I was introduced to Tableau, and that's where I fell in love. And as part of my grad scheme, I was lucky enough to spend 2 months actually working for Tableau, which was the most amazing experience. And it's where I got my real passion for spreading the use of Tableau across the healthcare services, because I just think it can add so much to the work that we do and help patients. So that's why I decided to become a leader. So I'm really excited to be a leader for you guys. We've got Ella. Can we go to the agenda?
You can. Sorry.
Thank you.
Oh, maybe.
We've got a really great agenda for you guys today. So we're just doing our welcomes at the moment. And then we've got Julia and Sarah from Imperial College Health Partners, who are going to talk a bit about the work they've been doing to support COVID. We will then move on to Ben from Cerner, who's going to do a bit of population health stuff. And then we're going to close and do a bit of a networking session that Ella introduced right at the start. So one of the reasons that I actually really fell in love with Tableau was the community. So having things like these user groups, but also having the massive community outside these groups. So these are some of the initiatives that if you aren't already involved in, then I really recommend that you do. Some of them are different challenges, or you get a data set and you have to make some visuals. It's a really great place if you're new to learn from others and to get some advice on how you could make the things that you're doing better. I certainly use it when I need inspiration. So I'll just search one of the hashtags on Twitter and I'll look at all the cool things that people have done and said, oh yeah, I could use that in my work. So if you aren't already, please do get involved in the community, because I think that's what makes Tableau really strong.
Can you see that? Oh. So the last thing to say is free stuff. Everybody loves free stuff, especially in NHS when we don't get that much freebies. So we just wanted to kind of highlight that the Tableau are currently giving away 93 days of Tableau e-learning, which is really useful. I don't know exactly how much it is normally, but anything free is really good. Lots of people I know have been using it. So it runs out at the end of June, so you need to sign up as soon as you can and start benefiting from the free stuff. So please do. And I think that's it. I think we can hand over to our first presenters. Let me stop sharing my screen. I can welcome Julia and Sarah over to the stage. Hi, Julia.
Hi, can you hear me okay?
Yep.
Right, so I'm going to attempt to share my screen, which...
Cool, I will.
So, Let me see if I can do this. Someone let me know when they can see my screen.
It's coming. It was coming through, but you might want to turn your camera off, just because your internet is a little bit unstable, and try sharing your screen again.
Right. Okay. I'll do that. Just shout when you can see it.
Yep, it's working.
Oh, brilliant. Okay. So if I press presentation mode, is that okay?
It seemed to when I did it. I'll let you know if it doesn't.
All right. Well, I've done it now. So let me know when it's come through.
Oh, it's working.
Yay. Okay. So hello, everybody. My name's Julie Wilkins. I work as Head of Data Analytics at Imperial College Health Partners. For those that don't know us, we're partly an academic health science network based in Northwest London, but we're also a healthcare partnership. So we're funded by our local organisations, our CCGs, our trusts, our universities, and we're here to offer additional capability and capacity into the system. We've got a team of analysts and health economists, and I've slowly one by one converted them all to Tableau, and we've got a Tableau server. So we've been using Tableau for about 18 months, maybe slightly longer now. And I have to say, it really came into its own during the COVID emergency response. When COVID hit and they realised it was going to be a big problem, they set up a Gold Command team in Northwest London made up of senior managers across Northwest London to coordinate the emergency response. And as one of the partners in Northwest London, we were brought in to help support them in terms of analytics. As you can imagine, things were very, very fraught. There were people 24/7 in the office, people working shifts on site and remotely. And there was a very high demand for accurate data and information in a format that they could easily understand. A lot of the Gold Command team weren't data specialists, but they needed to make decisions very rapidly. So there was a lot of pressure to get information together, specifically for ICU in the early days in terms of capacity. And that was pretty tricky because we had data feeds coming in directly from all of our trusts across Northwest London, using a couple of different data sources, including SITREP and other perhaps more unconventional data sources, but we had to do a lot of data prep to bring these all together. That data was updated 3 times a day, so we had lots of late nights and early mornings across the whole company. We had various people feeding into that work, I say the biggest challenge in the early days really was data prep, and I've just got a picture there of the back end. So it was a huge challenge, and I have to say a big thank you to Steve Adams, who helped us enormously and stepped up and really was a core part of the ICHP team. He again had some very early mornings, very late nights, helping us all in a very stressful situation. So big thank you to him. So data prep was a huge challenge. Data coming from lots of BI teams across Northwest London, and as you can imagine, the data wasn't necessarily that consistent across all the feeds. So like I say, we had multiple analysts with different skills all working remotely and on site. What we found was that they wanted that data turned into something they could easily understand. So Tableau was the obvious choice, and the great thing was there were quite a few of us trained in Tableau, so daily iteration based on the questions they were asking at every meeting was possible because we had the skills within the team and being able to supported by Steve, but also you know, we because it was done in-house, we could do it very, very quickly. So and having the Tableau server was exactly what we needed. It was a secure place to put sort of important information that people could access very easily, because obviously, you know, we were worried about sort of people going off sick suddenly and what have you. So having the Tableau server really helped us. So data quality, we had to build in a function so that anybody who was logging into the dashboard could see what that data was made up of, and in a way that they could easily understand. So we had to be very transparent about what was driving the data. So we built a sort of a tab which was hopefully, you know, sometimes, you know, when you look back at what we've created, you think, oh, maybe that wasn't quite so pretty, but because it had to be done very, very quickly, and the way in a way that people easily understood, we didn't have much time for a design cycle and user testing. We really just had to put something together very, very quickly. So this view at the bottom was around helping people to understand where the gaps were in the data as it was coming through. So we had to build on the data that we were given. So it was really important to help them understand what was driving those numbers. So just jump straight into it. This is the one that is live at the moment. You know, it didn't start off like this. The top right-hand chart was the one that we started off with some forecasting numbers in there that was, as you can imagine, reforecast on a daily basis. And as the questions evolved, so they wanted to know, you know, our mechanical ventilation numbers, in terms of capacity, unoccupied, expected changes, and really, you know, were we going to breach at any point? And you know, we didn't, thanks to everybody's hard work on the front line. And then over time, you can see at the bottom, we wanted to look at sickness rates. So obviously the number of ventilators was very important, both for our confirmed COVID and non-COVID patients, but also did we have enough staff? So monitoring staff sickness was very, very important. So we went through quite a few iterations, and the iterations got to this point, you know, sort of mid-May, and since then this has been updated on a once daily basis, and has been very well received. And once they got a taste for what we could do and how quickly we could do it, we quickly got asked to do more things, as you can imagine. And that's my seamless handover to Sara, who's going to talk to you about another dashboard we've created using Tableau. So I'll stop sharing now.
Great, thank you, Julia. I'll attempt to share my. There we go. I hope this works.
Yeah, I can see it.
Perfect. So as Julia mentioned, a number of analysts and economists from our team actually went, to be on site during the COVID crisis. And this is now maybe 10 or 12 weeks ago that we were originally on site. And it's a combination of remote working and on-site working. There were a few themes developing around the response to COVID, one of which was out-of-hospital care, and I was joining that kind of platform with my colleague Ellie, and our main focus was to look at the care homes, the situation in care homes, and what we can do to support local decision-making. To take you through our journey, so the main task was to create an interactive dashboard that would support daily decision-making in Northwest London. So this was both on a commissioner's level, so high above occupying the whole of Northwest London, but also on a more local level, so going down to CCGs, local authorities, and care home leads themselves. And the main thing we wanted to explore originally was, what was the capacity in care homes? Do we have any information on infection rates across London, Northwest London? And can we identify those residents that are most at risk of both getting COVID and adverse events? And the metrics of interest we identified in the beginning were the care home capacity, both original capacity and changed capacity during COVID, number of residents currently in the care home, but also number of residents who are displaying symptoms, mortality, and staff availability to conclude. There were a couple of data sources that we explored that could answer these questions, and one of them was Whole Systems Integrated Care, so-called WSIC, which is our local linked data set of primary, secondary, community, mental health, and social care linked on an individual patient level. And we built a kind of a matrix team. We worked across with the Northwest London Gold Command and Northwest London BI teams to identify best data source, sorry, and appropriate visualizations to use. And this originally started with, we want a map, and on the map we want all care homes and all of the metrics we identified of interest that we can flip between them and see visually where are our hotspots. And the first iteration of the dashboard included maps of Northwest London and each individual care home. And we quickly realized that it wasn't really supporting decision making, and that they wanted something much simpler. The maps were great and it made everyone happy, but we always kind of opted out back to the tables and simple graphs to show progress during this time. So two options with the data source we had, as I've said, option one was WSIC, and WSIC would enable us to answer the question vulnerable patients, also on care home capacity and current number of residents, as it holds a flag for each patient that lives in a care home, and also the basic information on care homes as well. However, the questions on number of residents with symptoms, staff availability, and mortality could not be answered at the moment. Option two was the ADAS dataset, which stands for the Association of Directors of Adult Social Services. And this dataset is a local dataset. Basically, it's self-reported data from each care home on a daily basis. All the care home leads would get a set of questions that they would have to answer and submit by noon. And then the data team from ADAS was basically building reports based on this. So as you can imagine, every question could be interpreted differently, and we did explore this in terms of the data quality as well. This data set would enable us to answer all the gaps that we had from WSIC, but we wouldn't be able to identify vulnerable patients because we don't have their information. We just know how many residents are in the care home. So in the end, we've decided to focus on the ADAS data set and then work on the vulnerable patients as a separate thing through WSIC. So in the end, we had the following key metrics in the dashboard. So number of residents displaying symptoms, number of residents who displayed symptoms and died, number of voided beds, staff absence rate, and reasons for not accepting any further patients or residents. The key thing was that in the ADAS dataset, originally they did collect mortality data, but this question was not answered after a few weeks. So we've decided to opt to use the ONS data that's publicly available and just filtered it down to Northwest London level. So coming to the dashboard itself, as you'll see, it's pretty simple. It answers the questions and it enables the commissioners and local leaders to identify care homes at risk. And to start off, in Northwest London, we have 8 CCGs, and for our clients, it was really important to get a fast overview of what is the situation. So we proposed to build a summary page without any graphs, with just summary information on what is the data situation today. So if we updated the data today, can we see by each local authority how many residents we have, how many homes have submitted the data, what was the change in the metrics of interest since previous day. This worked quite well because it was used for the daily updates for the local leaders and their decision making. But then as you went through the dashboard, you could explore these metrics in more depth. So we looked at the number of residents who are displaying COVID symptoms throughout time and their proportion as a total number of residents. We also split all of these views by local authority. And if you were the user and you were involved in local decision making, you could drill down to the care home specific level. So if you were in Brent, you could see a list of all your care homes and the current situation and changes in this metric as well. And this is kind of what the view was. It's just the data that for individual care homes is not present at the moment. But basically, this enabled our local leaders to follow the trends and also investigate whether additional support is needed in any care home. The ONS data was built in to represent the deaths, and it's updated weekly, has a bit of a lag to it, but we do tend to update it every Thursday now. And it's kind of the same principle. You'd still drill down to your local authority level and see your deaths involving COVID-19 and also all-cause mortality. The thing we were really interested in was the proportion of unavailable staff, and this metric is split into care staff and nursing staff, which was very useful for our commissioners. And the impact this graph potentially has had is there one of our clients, who is a chief nurse in Northwest London, built a pool of nurses who were able to, go to individual areas or individual care homes when support was needed. So we were able to quickly identify which care homes, have a higher percentage of unavailable staff and where they would benefit from the pool of nurses that was combined. And as a portion of the questions that were answered, each care home was asked the question of, can you take more residents in? And if you could, you would just answer yes. If you couldn't, you'd had a few follow-up questions on what is the reason behind this. And so some care homes simply don't have the space, so there isn't a physical bed to use, but also some care homes have reduced their capacity for risk of infection or staff availability or lack of PPE. So we combined all of these results to show which care homes can take new residents, but also for those that can't, what are the problems and how can we help out with manipulating those. And the last metric we looked at was voided beds. So this was the number of beds that cannot be occupied either because of the risk of infection or lack of PPE or staff availability. This metric is also represented on a daily basis for each care home, and it currently represents the difference, mathematical difference between capacity, available beds, and residents in the home. And by that, it might not be accurate, completely accurate, but it's the best estimate we have on what are our care homes at risk, and when can we look into shifting residents or new patients across to anticipate their needs. So the future of this dashboard currently is it's updated twice a week to support local decision making, and there are some additional metrics that we're looking at to incorporate together with ADAS, and it's been a great, absolutely a great piece of work to be involved with, because we could see the impact of the data, but also the simplicity of manipulating the data on the day. And just because we were working, under high pressure, and the returns for these things were within hours, we're just extremely proud that we were able to, influence decision making on the day, and complement the use of Tableau in these situations, because it really enabled us to quickly show what our clients wanted to see, and quickly support decision making. So with that, I'll stop. Happy to answer any questions in the Q&A chat, and thank you all.
Brilliant, thank you, both of you. That was really interesting. That was great. There aren't any questions in the Q&A. So I wonder, or people haven't worked out where the Q&A is, or there isn't any questions. But Sarah and Julia will be on a specific table that's, I think, named Speaker One when we start the networking event. So if you want to jump on that table with them, guys, then you can have a chat with them and ask them any questions about their presentation. Ben, can I invite you up to the stage? You just turn your camera mic on. It should appear. Oh, there you go.
Yeah. Oh. You see my lockdown haircut, so I might turn that off.
I'll let you take over if you want to start sharing your screen.
Yeah, absolutely. 2 seconds.
Great, thank you. Over to you.
With that. Cool. So good morning, everybody. My name is Ben Bell, Senior Business Intelligence Developer from Cerner's Population Health Analytics team. And I'm really, really excited to get the opportunity to present at this Tableau user group today, talking about how we can use HealtheIntent and Tableau to know, engage, and manage our populations. Been an avid attendee at this user group over the last, I'd say, year, 18 months. We found it as a team, as we've grown using Tableau internally. Really, really informative, and in turn, we've also mentioned this lots of times to our clients to in turn attend as well. And I've also plugged the Northwest one quite a few times, Ella, that you'll be pleased to hear. So we know that health and care needs are changing. People's lifestyles are increasing our risk of preventable disease. Organizations are now challenged to not only care for our patients, but manage the health of entire populations. Populations who are living longer and where the health inequality gap is rising. Remaining competitive and understanding this population depends on centralizing strategic information from various sources, streamlining data access, and facilitating analysis of information. Over the last couple of years, pretty much in my entire time here at Cerner, we've redefined our sort of approach to PHM, population health, and also analytics as well. We've taken a lot of lessons learned on board as we've taken on more clients, and we've redefined and reapproached how it is that we come about for population health analytics. So you can see from this slide here, we're focusing around the 3 I's, around infrastructure, intelligence, and intervention. And now our team has grown exponentially over the years, not just within analytics, but across the whole spectrum of pop health management. We have a team of expert data translators, people with deep technical experience, and people with clinical and NHS backgrounds, really making this a fantastic team that can support teams on the ground to use that intelligence, the infrastructure that we can provide, to make a real change. So some of the clients we work with in the EU here on the screen, and it's been really exciting and interesting to see how this has developed over the years, working from our typical acute partners. From obviously some of you in this room may know our Millennium side of the business, but you don't necessarily have to be a Millennium client. We've branched out and we're working now with STPs, as you can see there, with North London Health Partners, integrated care systems, and indeed even entire regions of a particular country, as you can see there with Sweden, with region Skåne. So branching out into the European space as well, covering about up to and over 10 million lives, which roughly is about 15% of the country, which is really, really exciting, and just all that data that is available to us, truly big data. Of all of those 10 plus million lives, there's about 18 petabytes of data currently in HealtheIntent. That's globally, to be fair. The last time I checked that statistic. And so for those storage nerds out there who are wondering what a petabyte may be, 1.5 petabytes is probably roughly the size of the 10 billion photos that are stored on Facebook. And 20 petabytes is the total hard drive space that was manufactured in 1995. So when you think we're up there at 18 petabytes, it's an awful amount of data that we've got available to us. So just to explain our data platform, HealtheIntent, before we get into some of the Tableau visualizations and some of the glamorous stuff, I was talking there just the sheer amount of data, big data that we have available to us. HealtheIntent is our big data population health platform. It is solution agnostic, so it can accept data from any source, in any format, in any frequency, ideally as real time as possible, and it does not rely on a single unique identifier. We have a proprietary data ingestion process, as well as probabilistic algorithms to help make sure we match all that disparate data together appropriately. From that, we then normalize and transform that data into single concepts, so that dynamic decision support, things like analytics and research, and new knowledge discovery can then be achieved. So that data coming through HealtheIntent powers certain solutions and products. Healthe Analytics, our web-based analytics portal, being one of them. And this is where we're going to start getting into the Tableau side of things. So the Healthe Analytics web platform allows personalized analysis of that HealtheIntent data from across the entire care network, not just an acute provider, it's the entire care network. So our clients or end users can create their own dashboards or metrics based on their priorities. It's very, very easy to create data models and visualizations using Healthe Analytics and of course Tableau. These can then be shared and managed via this very same web-based platform across individuals from that entire care network that we've taken the data from. The speed to insight is streamlined, so we can utilize we utilize Tableau in that instance as a fantastic data visualization tool to get that insight from the data as quickly as possible. End users can then go and investigate that data without the need for analytics expertise. And this is where we're really seeing some interesting developments with our clients. This whole process is managed within the tool itself. So there's not separate logins or a multitude of tools that you have to go into. It's one single login, and depending on your access controls, it depends on what you're able to do. So everything from querying that data, to data sets, data models, creating Tableau visualizations and Tableau dashboards, to then sharing that content is all centrally managed using this tool. So just with a quick background there around sort of very, very quick, obviously I could spend a lot more time there, but we've only got 20 minutes. I'm really excited to talk about how we've used HealtheIntent, Healthe Analytics to then go and work with our clients around what their population health priorities are, and obviously then analyze and visualize that using Tableau. So at the start of any population health management program, and where we've really taken lessons learned over the last couple of years, where we've turned up on site, we're starting a population health management program, we've got this fantastic big data platform behind us, and we pose the question, what are your priorities? What do you want to go and investigate? What are you looking to solve? And we're usually met with blank faces, or we were met with blank faces in the past, as people may understand that at a national level that we've got particular focuses, and diabetes is a problem nationally, so we think we should be doing something with that, or this person a year ago said it was COPD, so maybe we should go there. So we started to think around what our approach should be here, and we started to think we need to just understand the population in the first instance. What does my population look like? How is it made up? And so what you're looking at here is our answer to that question, and sort of trying to help those initial engagements with our clients really drive towards what their aims and objectives for a pop health management program should be. So the population profile is quite a simple dashboard. It's also leveraging extensive sort of internal templating and visual design standards, which again, coming out of some of the prior Tableau user groups we've taken inspiration from. So everything tries to have a similar look and feel. But going from the homepage that you can see on the left, we have a number of key lines of inquiry. So what is my population makeup? So we could click the explore button into there and see things like key demographic, age, gender, sex splits. There's also some risk factors in there. So the proportion of my population who are maybe tobacco smokers or who have a high BMI perhaps. Further line of investigation are how the long-term conditions affect my population. And lastly, how does that population then interact with my entire care system? So if we were to explore how the long-term conditions affect my population, which is the dashboard to the right, we can search for any particular condition in that bar chart there with the wildcard search, but we can also see combinations of conditions. So you can see that asthma and COPD has been highlighted. You can see where within this particular geography that those people live. And for the geography nerds out there, it's no secret where this is. It's one of our development partners and longtime clients, the Wirral. So using this data very quickly, it's helping us understand what that population is. So we've used asthma and COPD as an example, and then we can see in the bottom right what the breakdown of those long-term condition counts is for individual conditions. So we can start to explore just what my population has in terms of long-term conditions, how many there will be people out there with over multiple comorbidities. And then we're sort of imagining this, that there's a little takeaway in the bottom left corner here, that if I was quickly running to a meeting or I wanted some information, I can see that broken down by the inequality factor of interest filter in the top. This is currently by PCN, but that could be by deprivation area or LSOA or something similar. So lastly, it's just then how does my population interact with my system? So using Tableau here and using the power of the data that we've got behind, we can hone into specific cohorts. So taking that very similar asthma and COPD, we can see where they are within the geography. We've got some brief information. We know what the demographics are. We can then land into how is that specific cohort of patients then interacting with my care system. So you can see again split by PCN. You can see rates for ACS admissions through the ED attends, inpatient, outpatient. We can expand this to the number of GP appointments that this particular cohort may have. And we can see that utilization change over time as well. And as we onboard more data sources through HealtheIntent, things like adult social care, mental health, and others, we can also plot these into this same care network graph. So using that approach and working together closely with our client partners, the Wirral denoted that Frailty was going to be one of their first big areas for population health management and one of the real key areas for action. So we all know that there are an increasing number of elderly patients utilizing both primary and secondary care services and in various states of health. Frailty is how we quantify that accumulative negative effects of aging in a modern society, taking into account not only the recorded diagnosis of a patient, but also factors such as polypharmacy, social isolation, and others. The concept of frailty captures a distinct health state in which multiple body systems gradually lose their inbuilt reserves. So the idea behind this frailty dashboard really was to gather requirements for the exploration of health and care of those frail patients across the entire spectrum of the organizations up at the Wirral. We wanted to really create a way to interface with that single source of truth and that data that's provided by HealtheIntent. And the requirements for this dashboard, they really did range from being very strategic, as you're seeing here with the overview dashboard, to being patient-centered. And so we'll see shortly just how that they've been manifested. What we felt was really, really key, though, to this dashboard was providing an interface which could be used to both explore that data at the desired pace of a user, but then also when it was needed, to be able to arrive at that actionable insight through a minimum of a few clicks. And this is obviously where this is Tableau's bread and butter. And the more that we present this dashboard to clients, the more that we're seeing a great interest in it. So the data that's sitting behind this dashboard, it's largely powered. So for Frailty, it's the EFI risk stratification tool, so the electronic frailty index. And so this is a frailty score, which is calculated by the presence or absence of individual deficits as a proportion of the total possible. So categories of fit, mild, moderate, and then severely frail are assigned based on that score itself. So to look at the Frailty dashboard overview here, very much that strategic view. So we can see that the EFI score currently is only calculated from the primary care data, but there is enhancements and work ongoing to supplement that with other care, with other bits of care data. So you can see very quickly across the top some KPIs or bands, if we want to use some very nice language. Typical, where are they in the geographic distribution, population pyramid, but then some very interesting, what are the factors associated with frailty, so those deficits that make up that frailty score, and then how does that frail population interact with other points of the system. So you can see here a very quick line chart to understand those secondary care encounters. So again, we can hone into specific very, very quickly, and you're all aware as Tableau users that we wanted to drive into very specific cohorts of patients. So we can see here, there's quite a lot of frail patients living in the very south of Wirral. Believe it or not, that's where the majority of care homes exist in that geography, so it's unsurprising. So to go into a little bit more detail, we can examine the prevalence of those individual deficits from that frailty score across the entire population. This allows us to investigate those primary factors of frailty. We can then also see how they compare across the entire frailty severity spectrum. For example, like taking this chart here, we can see that almost every single severely frail patient is polypharmatic. And indeed, polypharmacy is one of the most prominent frailty factors. Now, that may be understandable, but some of the more interesting findings we can take from this analysis and this chart come from the difference in prevalence between severities and the increase in patients with things like dyspnea or hypertension, and the differences between moderately frail and severely frail. These findings are really useful, and they're the starting points for further investigations. Just to take my polypharmacy one for an example, like you're 300% more likely to be admitted to the ED if you're a polypharmatic patient. So using this analysis, using this data, we can really, again, I can't stress this enough, hone into specific, very, very targeted cohorts of patients where we can start to create those targeted interventions, truly starting that population health management journey. So again, here, just to look at this in a bit more granular detail, the similar cohort of patients, you can see the EFI classification and how it's gone over the last couple of years, and then with some forecasting using the Tableau features there. Selecting a delivery point of care, we can see how it interacts with A&E attendances, elective admissions, and those emergency missions. So where this tool may be more familiar to those of you with perhaps clinical backgrounds or who are indeed clinicians by background, is with case finding tools, and this specific case finding tool here. A lot of our dashboards and the work that we're carrying out combine a mix of a strategic overview and then with a case finding tool to really, again, help us really hone into cohorts of patients. So you can see that this tool displays at a specific record level where each patient is split by their EFI category, their age group, whether or not they have a diagnosis with frailty from a GP, whether they've had a falls risk assessment, a comprehensive geriatric medication review, and a medication review, We can also see, and there's great work carried out by associates from our team around identifying whether this person may or may not be a care home resident. So there's an algorithm that runs from the HealtheIntent data, and it looks for specific words in addresses, and then to a 99% accuracy denotes whether or not this person is a care home resident. So again, we can then split this by a particular organization using the area type filters at the top, or indeed specific levels of geography using the area selector. We can also isolate those patients whose frailty status has deteriorated within the last 2 years with the EFI classification 24 months filter at the bottom. So you can see people who may have jumped straight from mildly frail to severely frail in a relatively short amount of time. So these transitional states of health are really, they are the key to the delivery of anticipatory care. And this is where we're working quite closely with users on the ground up in the Wirral, community nurses especially, to implement this into their care and into their BAU practices. You can see just very quickly here, I can hone in very quickly, I can find all of those patients that the data itself is saying that they're severely frail. They don't have a diagnosis of frailty from a GP. They may live in a care home and they're yet to have a full risk assessment, a CGA, and they don't have a medication review. If we were making a working list for frailty of people we want to go out and create interventions for, just very quickly here, in a few short clicks, export that data out into however you see fit, and we're away. Really is fantastic stuff. And just lastly from here, from that individual record level, we can jump into one of our other HealtheIntent solutions. So this is displaying, this is just demo data, by the way. There did used to be a sign that said that on the screenshot, so apologies. But this just displays all of the data that's held in that longitudinal record from HealtheIntent. So from a short click, from this dashboard, I could click into this and it would open up as a URL action, and it would open up the Healthy record so I can see their data. There has been enhancements, or there's been talk of including some of that information in a tooltip. So a visualization in a tooltip, I can hover over individual elements on this case finding tool, and I'd be able to see that data within the dashboard itself. Cool. So what's coming next specifically with this dashboard? I'm working very, very closely with Wirral as one of our champions, not only for HealtheIntent, but for Frailty itself, is to keep developing that network of Frailty champions and seek to create a Frailty forum so that we can promote, or the Wirral, the Healthy Wirral partnership can promote a consistent and universal awareness of understanding frailty. So this is going to feed into the development of new care models. So the analytics that you've seen here today is going to be used, or is being used, to inform the development of a new target operating model. So this is going to describe how multidisciplinary teams are organized and arranged to support older people within our place-based care system, or Wirral's place-based care system. Also concurrently with new contracting and commissioning models. So there's been a focus on population segments and risk stratification. And this supports a shift in focus from designing and commissioning services based on utilization and financial measures, for example, to designing services based on what the population need is in terms of health and care. So all really exciting stuff coming from the Wirral, but they're not obviously the only client that we work with towards population health, and obviously working within Tableau. So coming up next, and obviously 2020, as you can imagine, was slightly derailed by that pandemic, COVID-19. So a lot of our 2020 so far has been a part of like how we've responded to that. So there's been great work carried out on the COVID-19 work in our respond and recover phases. But as we move back into more of a business as usual for population health analytics, we've got more specific condition focuses coming back up. So diabetes packages, COPD identification, continuing on the great analysis and things with further population segmentation, further risk strat analysis. We've got things on medicines optimization and specific PCN analytics. But then also very much inspired by what we're all doing here today is the development and the upkeep of a specific client community. So all of our HealtheIntent clients that you can see on that very first slide, they can come together and do, hopefully, my goal and my dream is that they could all come and do very much what I've just done today and showcase what they're doing in their pop health management programs, develop how they develop specific Tableau tools and tips and tricks. And again, I'm really, really keen to try and get some of these clients to present at this Tableau Healthcare user group as well. So I'd love to spend more time talking about this. I've got a particularly dry mouth as I forgot to get a glass of water. But if there are any questions, I can't see the chat at the minute, but I will be sticking around on the tables for the networking session. And I do believe that some of my colleagues have infiltrated this Remo as well. So I'm speaking to them directly. You maybe want to stick around as well if there are any questions. But thank you all for listening. I hope you found that informative and interesting.
Thanks, Ben. That was there was one. Got a bit of an echo. Ben, will you just mute for a second? Oh, he's gone. There we go. So there's one question for Ben around whether Cerner develop all of these health dashboards or care systems. So if you've got questions for Ben, I'm just conscious of time and allowing enough time for you to network and jump on tables. If you want to jump on speaker 2 table and have a chat with Ben and ask the question directly, I'm sure he'll be able to answer. So we've just got one final slide before we start the networking event. So let me see if I can successfully share my screen a bit better than last time. Give me a second. Oh no, I'm not from the beginning. See, still failed miserably. Just to say a couple of last things before we go. For future events, you will get notified of any future events that we hold now that you've attended one of these. But if you have other people that are interested in the healthcare user group and want to know when the events are, you can subscribe to the top link, and that will you'll get notification every time we have a new event. We do have a forums page as well, which we'll share after this event, and we normally post all our slides and presentations there. So again, we'll try and send a link out to that once we've got them up there. And also just to give a big plug, as you will have imagined, the Tableau conference, the Tableau Europe conference that's normally held around the end of June, obviously is not going to happen in its current usual state. So there will be a virtual Tableau event called Tableau Live. And literally this morning, as we were starting this event, they've released the registration details. So on the 30th of June, they're having a full virtual event. It's free. So that'll be music to our ears in the NHS world. So you can register now, and I'll highly recommend it. And then just to say, there's lots of other user groups. There's lots of regional user groups around England that are always useful to go and meet other people in your area that are from lots of different industries that are always good to kind of share ideas with. There are kind of specific ones around server and community-based ones, so it's always worth kind of keeping an eye out on all the user groups. So if you're on Twitter and LinkedIn, normally they get shared on there. So have a look around and see what other ones that might be of interest. And then just to say a big, massive thank you to Lorna, who's hosted today and helped us navigate us through Remo. Lorna works for Information Lab, who kindly provided the licenses today to run this event on Remo. So a massive thank you. Thank you, Lorna. Let me stop sharing. Oh. There we go. So just to say thank you for everyone attending. We're going to move into the network event, so please stick around. As I mentioned before, we've got lots of tables that have got a little sign underneath that says the topic that you can jump on that table to discuss. You can always jump on another table if you want to talk to certain people, but please jump on there. We're going to try and host a table each. So Emma, I think we're going to set up a newbies table. I think you're going to host that one. So there is one for anyone who's brand new to Tableau who just wants to chat through that kind of stuff with Emma and other people. And then there's lots of other tables that might be of interest. So if you will automatically be put on a table when the presentation mode stops. And then to move tables, as I said, just double click and jump onto that table that you're interested in. You might have noticed there is a second floor. So if you appear on the second floor and there's nobody there, that's because you're on the second floor. So on the left hand side of the screen, you'll see there's a 1 and 2. So click on 1 and jump down to the bottom floor and pick a table. I think that's it from now. We haven't got the next user group planned, but presumably it'll be another virtual event. If anyone wants to speak at a future event, just give us either me, Emma, or Chris a shout, and we can get you scheduled in for a future event to speak at. So thank you very much for coming, and I hope to catch up with you in the networking bit. Emma and Chris, I'll let you say goodbye.
Bye from me.
Bye, guys.